Continue on with the series on the insurance basics. I skipped the CMS 1500, so this would actually come after the CMS 1500 in your study guide. So what we're going to look at is the insurance basics, so different terms as well as the specifics that the certified medical reimbursement specialist focuses on for insurance specifics. The very first thing is the definition of health insurance. So it is to provide coverage for payments of benefits as a result of sickness or injury, including losses from accident, disability, medical expenses, or accidental death and dismemberment. So as far as when they ask the definition of what insurance is, that's what the CMRS is looking at. It is complicated because of the regulations, the forms, and the terminology. So being trained in medical billing specifically helps, as well as when you're out in the real world, you're going to focus on the insurances that are specific to your clinic, or if you work for a specific billing company such as Blue Cross Blue Shield, you're going to focus on the intricacies and the terminology and the specific forms specific to them. The National Health Expenditure Facts. So with that, we look at the total of what the United States compared to the rest of the world spends on healthcare annually. We as a country continue to increase on the amount that we spend towards healthcare, and it is only going to continue to increase as the years go up. So we see a projection towards the end. But right now, as of 2018, because they haven't posted the 2019 facts yet, it'll be closer to the end of the year when we get that. Medicare accounted for $750.2 billion, or 21% of the overall healthcare costs. Medicaid, $597.4 billion, or 16% of the total. Private insurances is $1.243 billion, or 34%. And then out-of-pocket expenses for people was $375.6 billion, 10% of the overall cost. And prescriptions, $335 billion. So when we're looking at prescription costs, insurance companies, especially for drug cost range, they have a wide range of, one insurance company may pay $4, and then you may pay $20 for that same prescription for another insurance company. So it really depends on generic versus brand. Sometimes brands are cheaper than the generic versions. So when it comes to how much we spend and what we need to change each and every year, that's some of the things. So if you use a particular prescription, or you know that someone that you handle their forms and their insurances, you want to look at the same insurance each year to determine, do we need to look at other prescription plans? Do we need to, how do we need to go about what we're going to spend? Another thing is, that's what you need to look at, especially when you're looking at those flexible health spending. That's where you're going to come up with that total. How much did you spend last year? Depending on how much your insurance coverage, that may not cover it this year, or it may surpass it. So you need to keep up with that. Projected, we're going to again continue to see this go up. So by 2028, our healthcare expenses that we spend overall will be $6.2 trillion plus. Our census data. So again, breaking it down by coverage. And this is just for the people that are covered. It doesn't include those that do not have insurance coverage. And compared from 2017 to what we would have this year is going to be different because we no longer have to have, we're not forced to have insurance because of the fines that we would have at the end of the year. So that's going to change as well. So when we look at it, government, that's your Medicare, your Medicaid, and your military, is about 62.2% of the individuals that are covered as determined by the 2017 census. Private is your employer base, so your group insurance, or what you purchase directly through like Blue Cross Blue Shield or one of the small co-ops that you're purchasing, is about 37.7%. And then of that 37.7%, 56% of those individuals are covered by group insurance, whereas the 16% are covered by direct purchase. If we continue on, we've got insurance companies pay about 70% of the overall healthcare cost. So for some specialties, they may pay anywhere from 60 to 90%, depending on your deductibles, depending on the fee schedule that they have set up through the carriers. Commercial carriers want to pay less to provide a profit to their shareholders. So that's when we see that we have more bundled procedures. We see that what we're getting paid on our fee schedules fluctuates, meaning it may drop substantially this year, but increase the next year. They look at the cost of what it is costing insurance companies plus what it's costing the healthcare organizations to have these services. So 2 years ago is going to impact what the cost of healthcare is today. For your overall healthcare cost, if you are running your own business or you work for a small company, the amount of healthcare that was used in the previous year will go into consideration on what they're going to change your premiums the next year, especially if you have a small company and you have two people that have two large procedures that may have been very expensive, or healthcare may have been expensive. That's where we're going to see an increase. But they have insurance as one of the largest organizations. They have the most lobbying power because they have the most money to work with, and they do have a lot of power compared to other businesses. So when they go up there, they have the money to make to help influence the politicians on where we should be. All right, terms that we have. With our terms, we have the carrier. The carrier is going to pay the benefits to the insured or the TPA. So the carrier is the one that holds it, like Blue Cross Blue Shield or Aetna. The insurer is also known as a subscriber. It pays the deductible or co-payment before the carrier will pay, and the deductible is a specific amount the insured must cover. Co-insurance is the amount shared by the insured and the carrier, and copay is like a deductible, which it's charged per visit. So those are some of the things you're going to be asked on the certification. They want to see that you understand the difference between a deductible, a co-insurance, and a copay. The payer, the underwriter, the TPA, and the administrative agent, they are responsible for providing coverage per contract between the carrier and the insured group. So the underwriter, that's the one, we have multiple underwriters across different facets of business and organizations. The underwriters are the ones that look at the contracts and put all the stipulations in there. All right, our HMO, PPO, point of service, high deductible, with or without health savings plan. We have group, we have individual, government, self-funded, and consumer-directed policy types, categories. So the HMO, as far as questions, before I get into what they actually are, as far as questions go on your certification exam, you're going to be given examples, or you're going to be given scenarios to determine, is it an HMO, or answer true-false questions about these particular categories and terms. So the HMO is the most restrictive of these. It delivers care through a network. You have less freedom to choose a provider, the least amount of paperwork that has to be completed. Your primary care physician manages the care and refers you to a specialist. It does require you have a referral. So a lot of times your PPO, you can choose if you want to, if you have a PPO, to go to any kind of specialist you want, where an HMO requires you to get that referral. Out-of-network provider is not covered unless it's an emergency. And so emergency out-of-network services are covered at the in-network rates. So if you're out of state, you're out of town, and you have to go to an emergency department, it's an emergency. They're not going to charge you more because you couldn't make it back to your network. Non-preventative services requires the insured to meet the deductible. They require co-pays and co-insurance, and there's no claim forms. So that's one of the benefits of using an HMO versus a PPO. It's going to cost less. The PPO, it's the most common. Patient is limited to the providers in the plan unless they pay higher out-of-pocket cost. There's paperwork that's required. Deductibles, copay, and co-insurance is the responsibility of the insured. Provider files the claim. The amounts above allowed fee schedule must be written off. So what that means is when we look at calculating fee a little bit later, could we balance bill, or do we have to write off? So in this particular case, if the contract states that they agree to that fee schedule amount, then you can't balance bill the remainder to the patient. You only get the fee schedule. A point of service must choose a primary care provider, and it's a blend of both the HMO and the PPO. So more freedom to choose a provider than an HMO. There's a moderate amount of paperwork to see an out-of-network provider. You've got the PCP that coordinates all the care and referrals to specialists. You pay more for out-of-network providers. That's the PPO side of, or the HMO side of things, excuse me. Must meet deductibles for services other than preventative. Higher deductibles for out-of-network providers. Your co-insurance copay is higher for out-of-network. Excuse me. Let's see. I think I just pushed it. There we go. Okay. Next. All right, so our high deductible with or without health savings. So with this, you choose either an HMO, a PPO, or a point of service. Typically, it's a PPO that is chosen. We do have higher out-of-pocket cost, but the patient has a maximum out-of-pocket expense. So once they meet that, once you meet your maximum out-of-pocket, then the plan takes over 100% of the cost. Health savings account, it's non-tax monies used for medical expenses. And so you have it in the account, and you can use it for prescriptions. You can use it for any, for doctor's appointments, your co-pays, your deductibles, or co-insurance, excuse me. It does have a high deductible and high out-of-pocket expense, but you do get free preventative services. The group is mainly an employer insurance. So the more people you have on it, obviously we have lower rates because they can spread the cost out among those individuals. Individuals that leave the company can convert coverage to the COBRA, which is the Consolidated Omnibus Budget Reconciliation Act, is what that falls under. So no individual group members can be terminated from your group. So you either terminate the entire policy or you have to maintain it. You can't just terminate one individual. So if that one individual, say, had a very expensive healthcare problems, say they had cancer and they had to have chemo and multiple surgeries, you couldn't terminate them from the group. Coordinations of benefits. The coordinations of benefits, this is when you have two insurance providers, two or more. So, for example, you have your group insurance and then you have a Medicare age, or you have your insurance and your spouse has the insurance. So with this, neither carrier pays more than 100% of the total charges on the claim. So the primary carrier would cover their charges. And then once you receive that EOB back, then you're going to send it to the secondary payer. The thing here is we have to determine, which we'll talk about a little bit later, what is the determining factor on the coordination of benefits? Who determines what's primary and secondary insurance? Then we have individual. It's the same as group, but it is with higher premium, no discounts, or volume pricing. That's the insurance. Self-funded, that goes with it, and then consumer directed, that's where that falls under. Okay, government. It's your federally funded insurances. It's provided to individuals who would not be able to afford coverage. So this is with your Medicare, your Medicaid, and your TRICARE. TRICARE was formerly called CHAMPUS. That could be a true-false question on there. Just know that they have changed the insurance name. It's now TRICARE because we're looking at active, we're looking at retirees, and we're looking at the family of members of the military. So TRICARE, there's 3 groups. Self-funded, it's administered by TPAs, which is third-party administrators. The administrator performs services in the policyholder's name. Employer picks provisions to meet their needs. The TPA then collects those premiums. It's the easiest for carriers to deny coverage. The reason for that is because the TPA can actually interpret the provisions, and it may not be subject to the same rules as other insurance companies. So the way Medicare or Blue Cross would interpret the rules as far as should it be covered or not is not necessarily the same way a TPA would do it. So you could possibly have more denials using that self-funded. The consumer-directed driven incentives to control costs. The insured assumes a higher cost sharing expense, means that there's more of an equal payment out from the carrier and the insured. Plans are cheaper. It allows individuals to control the deductibles and catastrophic limits. So you can actually, it's one of those piecemeal plans where you pick and choose what's best for you. So now we have types of coverage. We can have basic, major medical, comprehensive, and then our comprehensive medical fact sheet. So with the basic, it's no deductible. There's low reimbursement limits. It covers hospitalization, surgery, doctor's visits, diagnostic tests, labs, anesthesia, emergency department service. They're limited according to the set allowances. So what that means is you can see so many visits. It'll have an allowance on the number of procedures you can have and doctor's visits. Major medical coverage is a higher cost covers the higher cost of major illnesses or injuries not covered by basic, and then higher deductibles with broader coverage. The comprehensive is a combination of both the basic and the major medical. We normally have, especially if you have insurance now, you're going to see you have an individual deductible as well as a family deductible. Family deductibles are limited to 3 family members regardless of size. So if you have 12 people in your family, it's still going to be only a deductible for 3. Limitations apply for the same accident or illness. Charge 1 deductible to the family for claims related to the same incident. So if you have one major motor vehicle accident or an injury, a flooding, something to that effect, they're only going to pay 1 deductible, not multiple. Let's see if that'll pull that up. Okay, so our health insurance online. It looks like it's trying to drop it. Our health insurance online, this is free healthcare coverage. So if this is one of your hyperlinks that's within the study guide that you may want to look at. Okay. Other coverage types that we have same-day surgery, we have disability, vision care, and accident. So our same-day surgeries normally pays 100% for the surgeon, facility, and anesthesia. The provisions are going to be determined by the carrier. So what is included, what's covered under your specific insurance. Disability covers the loss of income due to disability, injury, or illness. It can be paid weekly to the insured, coordinated with the employer. The insured cannot collect unemployment or work comp at the same time as disability, and do not pay until the 6th week of missed work. Our vision care reimburses for exams, lenses, and frames, and you do have a limited dollar amount for each year. Your accident, your injury coverage. So 100% coverage up to the certain dollar amount for that. And then many health insurance policies include an accident coverage. So getting paid, what's the role of the insurance carrier? So we need the notice and proof, paying a claim, confidentiality, denial of claims, claim fraud, and some red flags that we have. Notice and proof, this is the goal of the insurers, is to pay all valid claims promptly and with a minimum amount of paperwork. Group policies require written notice and proof of claim before they will pay. Paying a claim, you've got steps for reimbursement. I'm going to calculate the benefits in accordance of the policy, which is our fee schedule, our deductibles, our benefit formulas. You're going to determine who is to be paid, the insured, the beneficiary, or the provider. Denial of the claim. The claimant is not covered. There could be fraud or misrepresentation of the claim. Claim fraud, we have it's serious losses to the injury industry, which result in higher premiums. And that actually means an intent to deceive. So fraud means that you're actually performing that with an intent to deceive to receive higher or reimbursement period. And then our red flags, what's going to throw red flags up to our carriers? Material misrepresentation of facts. We have patterns of payment, exaggerations of injury, manufacturing complaints or symptoms. fictitious services reported, alterations of medical bills, non-existent insurance scams. And so that's some of the fraud that you may see. You have lots of questions on the certification about fraud. So I've touched on fraud and abuse several places within these prep series. So you may want to watch these a few times. Other information that you could possibly see is the coordination of benefits. So again, it's when we have two or more. The order of benefits determination. So who's going to pay primary and secondary? So with our coordination of benefits, it's either going to be determined by the provision written in the insurance, or if both has a coordination of benefits provision, then you're going to look at multiple things. So with non-dependent, dependent, insured person, so you're looking at the person that's actually insured by the carrier. It's the non-dependent is going to be first, followed by the dependent. So your insurance company, if you're the insured, your insurance is going to pay first, then you're going to use the other. Dependent child, parents not separated or divorced, you're going to either follow the birthday rule, whose birthday falls earlier in the year, or the parent with the same birthday. So if both parents have the same birthday, the person that has been insured the longest is going to pay. So the birthday rule follows, it's not yearly, it's just the month and the day. So January 1 would come before October 12th. So you're looking at their actual date of birth. Some insurance companies still do the gender rule. It's determined by the gender of the parent. Dependent child, parents are separated or divorced. You've got the first parent with custody of the child. So the parent that has custody, that's going to be the primary. The spouse of the parent with custody is going to be the secondary. And then the parent that does not have custody will be last. So that's 3. Or court decree. So court decree determines the specifics of your divorce. It's going to determine who pays for what. Active, inactive employee. So with this, benefits of the plan of the insured not retired or laid off before the person that's laid off or retired. So say my husband is retired, my insurance would pay first, and then his insurance would pay second. Longer, shorter coverage lengths. So the insured that has been covered the longest is billed first. Now we're into the insurance carriers. So this is specific on your commercials, your Medicare, TRICARE, Medicaid, workers' comp, HMOs, and PPOs. You're going to have questions. Again, you've got 46 questions that you have to answer, and it's going to be with the specifics on the different types of insurance carriers. So with this, we have medical claims processor. What's the definition of that? It's to facilitate the reimbursement process, and it is critical to understand how the 2,000 plus carriers operate in the United States with 3 to 4 times as many plans. So we have more than 2,000 carriers, and then we have up to 8,000 different types of plans that you need to know the intricacies of. Links to carriers. Within your certification, you're going to have links, and we actually talk about that in the next few slides, as well as the health insurance plan types. So we have commercial, we have the government, work compensation, HMO, and PPO. So links to health insurance carriers. In this particular one, we are going to look at the coverage, where we would find information. So there are multiple questions on the test that require you to select the correct web address for the insurance company. So if we're looking at a specific state, or we're looking at a region, say you have someone coming from out of state, you wouldn't necessarily know the specifics and how to get in touch with that particular carrier of Blue Cross Blue Shield. So you could Google in the search bar to find the carrier, so you get the list of locations to contact someone, to also find specifics. Individual or group contracts. With that, payments made to the beneficiary or provider that accepts assignment of the benefits. And then we have carriers purchase data from companies such as Nginx, McKesson for pricing, claims, and edits. And that's to identify billing practice. What that specific thing means is that at the end of the year, these companies are going to go in and buy that information to determine how many heart caths were placed, how many laceration repairs were done, how many hip replacements, knee replacements, those type surgeries, how many were done, what was the cost of that, so they can look at overall how much we're spending on healthcare and where the majority are being spent. So Blue Cross Blue Shield, again, you can go to Blue Cross Blue Shield .com, and that will help you answer questions. It is a nonprofit, provides health insurance to subscribers, insured. It was originally established for the insured to pay in advance for surgery, inpatient, hospitalization, and some outpatient emergency services. And they pay for medical care, but not hospital charges, is what that was for. So they pay hospital charges, comprehensive plans, merged plans, but remain separate entities. So you can have that's picking all the different areas you need. So your vision, your dental, all of those things, they remain separate. Your hospitalization, your outpatient procedures. Carrier pays participating providers directly. They can pay the beneficiary for non-participating providers. So again, we've got that participating versus non-participating. We're going to get in that again later. You've seen that in the stuff that you've been going over in Cengage. Participating means they accept that contract and they're going to accept that in full payment. Non-participating providers means they're not signing a contract with that specific payer. The state laws, although it says the carriers, if it is the beneficiary is seeing a doctor that doesn't participate with Blue Cross Blue Shield, they don't accept that fee schedule as payment. Some states mandate that they're still going to pay directly to the provider and not to the patient. And it's just to ensure that payment is made appropriately. So websites for Medicare, you can actually go out to Medicare and you can find lots of information as far as filing claims, what's coverage, the LCDs, the NCCI edits, fee schedules. They're all out on the Medicare website. And Medicare, the basics here, represents 15% of the total federal budget, and it was established by the Social Security Act of 1965 for people 65 and older, people under 65 with certain disabilities, people with end-stage renal disease that have permanent kidney failure requiring dialysis or kidney transplant. There are 4 parts. The 4 parts, Part A is automatic. You're automatically enrolled And it is hospital insurance to cover inpatient care, skilled nursing facility care, hospice care, home health. Part B, it is for those eligible, but you do have to enroll. The medical insurance covers doctor services, outpatient care, mental health and partial hospitalization, second opinions prior to surgery, ambulance services, home health care, durable medical equipment, preventative services such as your screening, shots, vaccines, yearly wellness visits. And then other facts that we need, their voluntary program. There's an annual deductible with 20% co-insurance. It does change January 1st of each year. Part C, it's our supplemental coverage. So it's the cover, it's also known as Medicare Advantage. It is known as the gap insurance. It kicks in where Part A and B leave off. So it's an all-in-one bundled plan for A, B, and C. Lower out-of-pocket expense may include additional services such as vision, hearing, dental, and more. You do have to pay separate for those. Part D is our prescription drug plan. So it's the whole purpose of that prescription plan is to lower the overall drug cost by ensuring that certain drugs that most individuals use fall under that. Payments. We want to make sure clean claims are normally paid within 30 days of receipt. Electronic claims will not be issued less than 14 days from the date of receipt. So even though you may get it in there, you're not going to see claim paid until at least 14 days. If they are denied, they're held an additional 14 days before they're sent back. Paper claims will not be issued less than 27 days. That's one of the disadvantages of continuing to do paper versus electronic. It's being penalized. And then if they are denied and they are paper, you're going to see 27. So it just doubles the amount of time that you're going to see that. How many Medicare claims do we see per year? So they receive about 1.2 plus billion claims per year, which breaks down to 9,579 claims per minute. Medicare, what it does not pay for. It does not pay for dental services to treat teeth, gums, or bone structures. Services done to prep for dentures, that's out of pocket. If you have any kind of condition that requires dental work before they can move on to have that procedure, such as a heart condition, then it would cover the tooth extraction, but it wouldn't be under dental. It would be considered medical insurance. Exams for prescribing or fitting eyeglasses or hearing aids. Again, you have to have a specific medical condition in order to get those. It's not a preemptive or preventative service. Mammograms are covered every 2 years. Pap smears every 3 years. Chiropractors are only for manipulations of the spine to correct subluxation. So it's not quite a dislocation. It's a sublux. So you're just kind of out of alignment. And then only covers diabetic mellitus type 1 test supplies. So it doesn't cover the insulin or the syringes, just the testing supplies. It doesn't pay for cosmetic surgery. Dentures can be considered cosmetic. Routine physicals, routine foot care, eye exams, and procedures not medically necessary to treat an illness or injury. So again, that falls under, you need a different coverage. You need dental coverage and you need vision coverage. Participating versus non-participating. So if we are participating, that's called PAR. and they accept assignment, meaning they accept the contract, the fee schedule that Medicare or the other carriers have stated is the fee schedule for that payment. Providers do not balance bill when they're par and they accept. Bill deductible or coinsurance. The payment is sent to the provider, and Medicare pays 80%. The beneficiary pays 20% after the deductible is paid. So they still have to meet their deductible, and then their fees kick in. PAR accept or does not accept assignment. So there's two here. So you could be a non-PAR and you accept assignment. So the payment again is sent to the provider and they receive 95% of the Medicare fee schedule. It's known as the non-PAR amount. So if Medicare pays $100, because they are not a participating provider, they're only going to get paid $95. Does not accept assignment. The payment is then sent to the beneficiary. We have a limiting charge. It's 115% of the non-par Medicare fee schedule allowance. So they're going to be paid if Medicare gets paid $100, they're going to get paid $115. All right, so we're going to look at the next. So PAR, when we're calculating these fee schedules, we're looking at PAR. So a patient receives treatment from a provider who charged $140 on their fee schedule. The patient's Part B deductible has been met, so there's no deductible that we need to worry about, and Medicare approves $100. That's Medicare's fee schedule. What does Medicare pay? Paid by the beneficiary, balance billed, and or written off. Who does Medicare send the payment to? So on this particular one, the provider fee schedule is $140. Medicare's fee schedule is $100. The difference is $40 here. Medicare pays 80% of their fee schedule because, again, we have met that deductible. So it's $80. The beneficiary pays $20. The write-off, because we cannot balance bill, is $40. And Medicare sends the payment to the provider. So non-par accepting. The patient receives a payment from the provider. Again, it's all the same amount. So because it's non-par and it's accepting, where does it get paid? Or where does the payment go to and how much? So again, we're looking at a non-par fee schedule for Medicare. So it's not going to be the same amount as 100% of what they were paid. So again, we still have the provider fee schedule and we have Medicare's fee schedule up there as 100. Medicare non-par, you're going to take the 100, which is their fee schedule, and you're going to multiply it by 95%. So it's $95 is the non-par amount. Medicare then gets 80% of the non-par amount, which is $95 times 80 is $76. The beneficiary is going to pay 20% of the non-par fee schedule. 95 again times 20% is $19. The write-off amount, we're looking at the provider fee schedule, subtracting Medicare's non-par fee schedule is $95. It's going to be $45. And then because they accept, the payment is going to be sent directly to the provider. And it's the amount. Okay, non-par, this should be not accepting. So I do apologize for this. It should say non-accepting. So there is a difference on the non-accepting. Again, we have the provider schedule. We have Medicare fee schedule. Nothing changes there. We have the non-par amount, so we still have to figure out the non-par amount, which is 95. But now we charge 115% of the non-par amount, which is our limiting charge. So it's $109.25. Medicare pays $95 of the 80% because we still do that percentage. Our beneficiary is still the same. The write-off amount, that's where it comes to what are we writing off. We're using the limiting fee here. So 140 minus 109.25 is $30.75. Medicare sends a payment to the beneficiary of $76. So the amount doesn't change how much Medicare is going to pay because the limiting fee is actually the beneficiary's amount. Okay, CMS monitor. So we have the different groups. You're going to have questions on who's responsible for the overlook and the management of different areas. So the types of claims. So our carriers and our Medicare Advantage contractors, they're going to monitor our physicians, our diagnostic and laboratory facilities and ambulances, our fiscal and our max. They're going to look at the non-PPS inpatient hospitals, outpatient hospitals, SNFs, home health, and our hospice. Again, we've got the PPS, and then our DME, our durable medical equipment, Medicare Advantage contractors are going to look at the DME supplies. And then we have how much they look at each. So Medicare cards, what you're looking at, you do have questions on old versus new. We've had these for a while, but there's a good chance that unless they updated the study guide, you're still going to have some questions on the difference. As you can see, our Medicare claim number before was a Social Security number plus a given A, the sex, it told what they were entitled to, and then when the coverage starts. Now it still tells the name of the beneficiary, but our number is on there. The Social Security number is no longer on there. The sex of the patient is no longer listed. We do have an effective date, and they do not have to sign the front. Now, if you go to the Medicare site, you can actually find the breakdown of what each character within that Medicare beneficiary indicator number stands for. So, and then what the setup is going to be. You do have questions as far as how many characters. It is 11 characters long. What's included, it's alphanumeric, the position. So this is something that you may want to take a look at. You may want to do your hyperlink to know where it's at, or print it off. Medicare secondary payer. So what this means is we have a primary, someone else pays, whether that's a group insurance or not, and then this is what kicks in after the fact. So Medicare is billed secondary or supplemental. If you have a group insurance and you're working, it's secondary when. So you do have questions that are specific to, would we bill Medicare primary or secondary? So these are some of the examples that you're going to look at, and you're going to have some specifics. So you just need to be able to determine and identify when Medicare is primary versus secondary. So if we have a working individual at 65 or older that they do have employer insurance, Medicare is going to be secondary. Spouse of an individual 65 plus, and they're covered by employer group plan. The employer group plan is going to do that. That was one of the ones we looked at a couple of slides ago. Retired versus non-retired. We're going to go with the insured person over the retired. Individual with prepaid plan is going to be paid before Medicare. If they have end-stage renal disease patients and they are covered by group, they're going to be covered by the group plan first. End-stage renal disease patients actively working under 65, so again, they would more than likely be under a group plan or a consumer-directed plan. Work-related injury or illness, so if you have work comp, you're going to bill work comp before you bill Medicare. Injury or illness related to auto, we're going to bill our auto insurance over our Medicare. Homeowners is the same way. If it was caused at the home, we're going to bill that over the Medicare. And then malpractice, liability, and general causality insurance, we're going to bill that before we bill Medicare. So we've got our employer group plan is going to be billed first. So if the provider's agreement with the employer group health plan is what that stands for, is to accept as full payment, you do not bill Medicare. So there's nothing left over. You've accepted full payment. We can't exceed 100% of the payment. Provider may keep full payment even if it exceeds the maximum allowable charge. So that could possibly be a true-false question. If they do receive more than the maximum allowable charge, they can keep it. Non-par participating, you bill your employer group using Medicare's higher fee for non-par CMS patients. So that's that 115%. Must submit employer group EOB showing the payment or denial with the CMS 1500 when billing Medicare secondary. So you have to wait. Once you submit it to your employer group, you have to wait until you get that EOB back for it to explain, did they pay, how much they paid, did they deny it? And if it's denied and Medicare covers it, then you'll send it to Medicare to receive payment. Auto or no fault coverage is then again billed first. Your liability participating require billing Medicare first for the conditional payment. Then you may bill the employer group first and Medicare secondary if that has to do with the work comp liability. And it's not allowed to bill liability carrier instead of Medicare. So it means you have to bill liability and Medicare. You can't just pick or choose. Medicare is secondary to group health plans for working aged, where either the single employer of 20 or more employees is the sponsor or contributor to that employer group health, or there's 2 or more employers are sponsors or contributors, and at least one has 20 or more employees. Your Medigap, your gap insurance. So coverage picks up charges Medicare Part B doesn't cover. If you picture a donut, your coverage starts at the outside of the donut and works its way in, and then you have that center that's cut out, looks like a donut, and then that donut hole is where this gap insurance fills in, and then you'll continue on to the next center of the donut to the outside. So that's where it's going to cover your deductibles and co-insurances. Medicare beneficiaries with gap insurance will not need to file secondary claim because Medicare automatically forwards that to your gap carrier. Medicare beneficiaries with Medicaid coverage. Medicaid is always secondary. It's secondary to everything. Medicare forwards payment or denial information to the Medicaid carrier, so you don't have to do that. It is known as welfare, Medi-Cal, access, or medical assistance. It's for the low-income adults, females with dependent children, needy persons who are aged, blind, or disabled is what Medicare covers. It is state and federally funded. It's federally funded, but state specific and ran, meaning that Medicare Medicaid is not consistent across all states. Each state is individual. They have their minimum and maximum amount. They have what they will and will not cover. And then the state determines how their money is spent. And then there's no deductibles or coinsurance for below poverty line individuals. Medicaid does not pay for non-trauma emergency department visits or lab tests. Those have to be covered by the individual or written off. Always bill secondary, and then again they reimburse about an average of 30 to 33% of actual charges billed. TRICARE, this was formerly Champus, so it is for active duty service members, National Guard, reserve members, retirees, their families, survivors, and certain former spouses. They can utilize non-military physicians, but there is paperwork that goes along with that. At the age of 65, beneficiaries are transferred to Medicare. So again, Medicare is an automatic enrollment. Benefits are paid to the beneficiary, so you have to pay the provider. Paid secondary to group insurance, so TRICARE would be secondary. And rank determines premium, deductible, and coinsurance. So the higher your rank, the lower your premium, deductible, and coinsurance. Workers' compensation, what's important here? It covers the medical and disability of injury or illness related to the job. It will pay for rehab, therapy, psychiatric, and social services. Employers are required to carry this insurance, and they must supply the date of injury, illness, name of the employer, and case number. Services must be authorized in order to be paid. So just because you fall at work, if you don't go through the proper channels, it will not be paid. Benefits, you have medical, disability, survival, and burial expenses depending on what occurred. And classification, we have total temporary, temporary partial, permanent partial, and total permanent payments. So that determines how much you will be paid and for how long. Temporary means that total means that you've lost total use of a specific body part, but it's only temporary. You can, with rehab and stuff, get back to that. Partial is only partial, like it's not your complete arm. It may be a percentage, it may be a finger. Whereas permanent, you're never going to get full use of those areas back. Your Federal Employees Compensation Act, you do have questions on this. It does provide benefits to civilian employees for disability due to personal or occupational injury sustained while working. It's administered by the Office of Workers' Compensation. Plug my computer in. Which is the OWCP by the U.S. Department of Labor. Our no fault. So with our no fault, let me get where I can read my stuff. There's no subject to coordination and benefits in some states, which allow patients to double up. So that means that if, for example, you had work comp and you were in an auto accident at the same time, both insurances could pay, as well as your medical Medicare in that as well. So the key parts that we have declaration, coverage, supplemental payments, definitions, exclusions, and conditions. Our declaration, we need our policy number, insured demographics, our policy terms, coverage limitations, auto descriptions, and loss payee. So that's the owner of the car, lender, or owner. So we need to know who's going to be paid under that declaration when there's total loss. Coverage, it's the liability. It can be liability, which is the bodily injury of the injured person, property damage, which is either damage to another auto or property. You've got physical damage, which is protect against financial loss caused by the damage to the vehicle. Collision, a deductible must be paid prior to the insurance payout. Comprehensive, it's going to cover your fire, theft, missiles, falling objects, larceny, earthquake, windstorms, hail, water, and flood. Your medical, it's also referred to as med pay, medical or funeral expenses for the individual riding in the insured car. That's going to fall under your conditions. Managed care, and this is the last one that we're going to look at, and then I'll stop this video. HMO and PPO, they're going to regulate the amounts charged. So the HMO, group of physicians, specialists, nurses, and other providers to provide the total health care. So that's your preventative, and that's your treatment of medical illnesses or injury. They're going to be prepaid monthly to the provider. Your PPO is going to use pre-negotiated fees for services. And then members are penalized for using providers outside the PPO. So this is under our managed care. They do pay copays in addition to monthly premiums. And we can have a capitation program, which that's a prepaid set amount paid monthly by the carrier to the provider. So the insured can go as many times as they want or as little as they want, and it doesn't change the amount that the provider is going to be billed. Depending on the provider, if they have a group of individuals that do not visit the doctor's office a lot, a capitation program works well for them because they actually make a profit. Whereas, say you have the Medicare group of individuals and they go to the doctor consistently as well as numerous times per month, they're going to surpass what they would be paid. Okay, so I'm going to stop here.